Iron deficiency is commonly imagined as a problem of young women and developing countries. The reality is more widespread and considerably more subtle than that image suggests. In aging populations, iron insufficiency, not always deficiency severe enough to appear on a standard blood panel, quietly erodes energy levels, cognitive sharpness, and immune competence in ways that are frequently misattributed to just getting older. Understanding the difference between heme and non-heme iron is central to understanding why diet composition, not just total iron intake, determines whether someone's iron status is genuinely adequate. Heme iron comes exclusively from animal sources, red meat, poultry, and fish. It is absorbed through a dedicated transport mechanism that operates independently of most dietary inhibitors, and absorption rates range from 15 to 35% depending on individual iron stores. Non-heme iron, found in plant foods like spinach, lentils, and fortified cereals, uses a different absorption pathway that is highly sensitive to competition from phytates, polyphenol, calcium, and other dietary factors. Its absorption rate varies dramatically, anywhere from 2 to 20%, and the lower end of that range is common when non-heme iron is consumed with foods that inhibit its uptake. This gap is not just a number. It means that achieving equivalent absorbed iron from plant sources requires consuming substantially more food, eating strategically, and avoiding common dietary patterns like drinking tea with meals or eating calcium-rich foods alongside iron-rich plant foods. For older adults with reduced appetite, smaller meal volumes, and often multiple medications that affect gut function, reliably meeting iron needs through plant sources alone becomes a genuine challenge. What makes this particularly relevant for aging is that iron plays an underappreciated role in mitochondrial function and oxygen transport. Mild iron insufficiency, again, not necessarily reaching the threshold of clinical anemia, can reduce aerobic capacity, increase fatigue with exertion, impair concentration, and blunt immune responses to infection. These are symptoms that in an older adult are often attributed to aging itself rather than investigated as potentially correctable nutritional issues. There is an important counterpoint that fairness requires raising. Excess iron carries its own risks. Iron is a pro-oxidant, and in individuals with conditions like hemochromatosis, a relatively common genetic condition that causes iron overload, high dietary heme iron intake can contribute to organ damage. Postmenopausal women and older men no longer have menstruation-driven iron losses, which means their need for dietary iron is lower than in reproductive age women, and the risk of accumulation increases. Supplementing iron without confirmed deficiency is never advisable in this population. The practical guidance here is to get iron status properly assessed, not just hemoglobin, but serum ferritin, which is a storage marker, and transferrin saturation. Many clinicians stop at hemoglobin, which only catches deficiency once it has become severe enough to affect red blood cell production. A person can have low ferritin and a technically normal hemoglobin for months or years before developing overt anemia, and throughout that period their vitality, cognition, and immune function may be measurably compromised. For older adults eating limited meat, this level of monitoring is not excessive, it is prudent.